Hey everyone, and welcome to our deep dive on hypernatremia. This is such a critical topic, not just for the NCLEX, but for your day-to-day practice on the floor. We're going to go way beyond just the numbers today to really understand what's happening. So let's get right into it. Okay, let's start with a scenario. Picture this. You're on your shift and your patient is agitated, restless, and telling you they are just unbelievably thirsty. What's the first thing that pops into your head? If your brain immediately screamed high sodium, then you are absolutely on the right track. That's the kind of clinical thinking we're going to build today. So here's our game plan. We'll start with the basics, what is this thing? Then we'll dig into the why, the causes, and what's actually happening to the body's cells. We'll cover what to look for, what you're going to do about it, and then we'll wrap up by sharpening those critical test-taking skills. Let's do this. First things first, before we can fix it, we have to know what it is. So let's build a really solid foundation. What are we really talking about when we say a patient is hypernatremic? Okay, here are the numbers you've just got to burn into your brain. Anything over 145 is hypernatremia. Got it? But that second number, 160, that's the one that should really get your attention. When you see a sodium of 160 or higher, you need to think danger zone. We're talking about a huge risk for some really serious neural complications. If you only remember one thing from this entire explainer, please let it be this. Forget about thinking there's too much salt. The NCLEX and really real-life physiology wants you to frame this as a water problem. The body is dehydrated. It doesn't have enough water to dilute the sodium that's there. This one little shift in thinking is the key to unlocking everything else. So if it's a water problem, how in the world do patients get there? Let's break down the most common reasons you'll see this. By far, the number one cause is just losing too much water. Think about anything that makes you dehydrated. A raging fever, bad diarrhea, or a condition like diabetes insipidus, where a person is just peeing out tons and tons of fluid. Another huge one is not taking in enough water. This is a massive risk for our little infants or confused elderly patients who can't tell us they're thirsty. And yeah, sometimes we can cause it ourselves by giving things like hypertonic IV fluids or not giving enough free water with tube feeds. So what is all this extra sodium in the blood actually doing? Well, it all comes down to basic osmosis. Remember, water always follows salt. So when the bloodstream gets super concentrated and salty, it acts like a powerful magnet, literally pulling water out of the body's cells to try to balance things out. The cells get dehydrated, and the cells that are most sensitive to this, yep, the ones in the brain, they literally shrink. And it's that shrinkage that causes all those scary neurological symptoms. See, once you understand the why, it makes the what so much easier to remember. So what are we actually going to see in our patient? Let's look at those clinical clues. You're going to see signs of this all over. You'll have those classic dehydration symptoms like a dry mouth, maybe a fast heart rate. You might even see some muscle twitching. But look at that top row, the one I've labeled NCLEX Gold. That's the money right there. Thirst, irritability, confusion, all the way to seizures and coma. They aren't just random symptoms. They are the direct result of those shrinking brain cells we just talked about, and they are always your highest priority. Let me just say that one more time because it's so important. Dry mucous membranes are a clue, for sure. But a change in mental status, that is a 5-alarm fire. On your exam, if you have to pick between the patient who's thirsty and the patient who is newly confused, you go to the confused patient every single time. Safety is everything. Okay, so we've identified the problem. We know it's serious. Now, what's our playbook? What are we going to do to fix this? And more importantly, how do we do it safely? The treatment makes perfect sense if you remember our core concept. It's a water problem, so we replace the water. But the key word here, the one I really need you to hear, is slowly. We'll use hypotonic IV fluids like half-normal saline or D5W because they have more water than salt and they gently rehydrate the cells. If the patient can drink, great. And of course, we've got to fix whatever was causing the problem to begin with. Okay, this is one of the biggest, most dangerous traps on the entire exam. Your first instinct might be to think, oh no, they're dry, let's slam them with fluids. No, do not do that. If you give all that water back too quickly, those poor shrunken brain cells will swell up like overfilled water balloons. This rebound swelling is called cerebral edema, and it can be just as deadly as the hypernatremia was. Slow and steady wins the race and saves the brain. As the nurse, you are the guardian of patient safety here. This means you are constantly doing neuro checks, looking for any subtle change in their mental status. You're tracking every single drop that goes in and comes out. You're getting daily weights. You're watching those lab trends to make sure the sodium is coming down nice and slow. And if that sodium level is really high, you're putting seizure precautions in place before a seizure has a chance to happen. All right, let's lock all this amazing knowledge in and give you that test-taking edge you need. This section is all about making this stuff stick so you can pull it out when it counts. Let's do a quick run-through of the traps so you can spot them a mile away. We already hammered on correcting too fast. You would never give hypertonic fluids. That's literally like pouring gasoline on a fire. You have to take thirst seriously in older adults. It might be their only clue. And finally, don't mix up the signs of dehydration with fluid overload. They can look similar sometimes, but the cause is the exact opposite. Here's your first memory anchor. It's so simple, but so powerful. High NAT equals a dry brain. Whenever you see a high sodium lab value, I want you to immediately picture a dry, shrunken brain. That will instantly remind you of all those priority neurosymptoms. Anchor number 2 is all about the treatment. What's the problem? Not enough water. So what's the solution? Fix the water first. It keeps your thinking simple and focused on the most important intervention. And your third anchor is your safety check. Why do we go slow? Because slow correction saves the brain. It prevents that dangerous rebound swelling. So you've got high neg, dry brain, fix water first, and slow correction saves the brain. You got this. Now, this slide is perfect for clearing up a super common point of confusion. Hyper versus hypo. They're opposites. With hyponatremia, you have too much water and the brain is swollen. With hypernatremia, it's a water deficit and the brain is shrunken. But look closely. Seizures are a major risk for both. Why? Because the brain absolutely hates rapid changes in cell size in either direction. This is a great little chart to look at right before your exam. Okay, time to put it all together. Here's your clinical judgment challenge. You've got an elderly patient, a known risk factor. They're on tube feeds, a potential cause. They're restless, a key neurosign. And their sodium is severe at 165. So think through everything we've talked about. Your assessment, your safety checks, your interventions. What is the very next thing you, as the nurse, would do? Think it through. Getting this right means you're well on your way to mastering this concept.